the title that Clive gave me, Treatment is Prevention a Decade Later After the Scientific Discovery of the Year. So let me go to the next slide. So this is the slide that the study that was highlighted by Tom as the sort of sister study to his own, published just a few months later. And the only message I want to take away is that we saw no transmissions in anybody with less than 3,000 viral load. Tom saw nobody in less than 1,000 viral load. And for two completely different studies that had similar research designs in completely different parts of Africa that were roughly the same size and roughly the same number of person years, to come up with exactly the same results was quite remarkable and certainly should have given a tremendous shot in the arm. And it wasn't for another decade until the Durban AIDS meeting that people started to say, why aren't we treating everybody in Africa? So this delay of research finding to public health implementation is similar to the delay that we see in clinical medicine, where we have an innovation in treating patients, and there's often a decade or more delay before it becomes standard practice. And that's a topic for a different day. Why does it take us so long from the point of discovery to the point of logical policy implementation? There are a number of studies, and Tom has highlighted this one, the ANRS TASP, which was disappointing. It did not have very substantial coverage when you think about 90-90-90, you know, especially that less than 50 second rung of transmission. So it wasn't a very good test of the concept. In other words, you can't say universal treatment doesn't work, because if you don't implement it properly, then you don't know if it works. The SEARCH study has much more optimistic data, and I commend this brand new paper in JAMA to you that is far more optimistic about the potential impact of wider spread testing, linkage to care, treatment in terms of impact on local transmission. This study is still going along, and they don't have data yet. The Botswana Combination Prevention Project, you can read about the research design in this paper from last year. Shikamana, you heard about from Deanna Kerrigan last night in her talk. And she just alluded to it on her very last slide. And if I'd known that, I would have put in a couple of slides from her paper in JADES just this year. But she is also seeing tremendous impact of key population intervention among sex workers if you have peer counseling, if you make testing available, if you educate the women, if you help them with self-esteem building, if you make it easy for them to get therapy, they will come. And that is the short version of a complicated story that Deanna can tell you another day. And the MaxArt in Swaziland, which is a combination of the Swazi government with a group from the Netherlands and some folks from Harvard School of Public Health. I've served on as the DSMB chair for that study. They also will have data coming out next year, and if you want to read about their design, that's the reference there. So there's a family of studies looking in real-world contexts. Does treatment as prevention actually impact community incidence? Because right now, it's a theoretical concept. It's not actually a demonstrated concept. I didn't put it, let me keep going, see if we'll get to all the topics. Now, Tom has already alluded to this, and this is why Clive gave it the title that he did 10 years after Breakthrough of the Year, because science, this study was published in the New England Journal, but science took it as the scientific breakthrough of the year for the year 2011, which is kind of a big deal because there are a lot of good scientific studies going out there. But being able to demonstrate in a clinical trial that you will reduce transmission to sexual partners if you suppress virus load was the first time it was done in that kind of a rigorous context. It made sense. Tom's study from long ago and the study from our group, Susan Allen's study, said it would happen, but it took ages to get this study funded, launched. Finally, it came out over a decade later, and then there was just no question at all that earlier treatment was indicated. It also found that the patients with HIV themselves benefited. There was substantial diminution in morbidity and mortality in the earlier treated patients. So not only did you benefit the patients, as any clinician will tell you, Jean could have told you that before this study was published, but also benefited the sexual partners. So it was a win-win. You didn't have to choose the benefit of one or the other. Early treatment benefited both. And the Walensky paper a number of years ago saying that was highly cost-effective. You're putting people back to work. You're making them the breadwinners of their families. You're avoiding orphans. You're avoiding widows. You're avoiding widowers. You're avoiding the upheaval of the costs of death. And so it's the right thing to do, and it's the cost-effective thing to do. Tom mentioned the 052 study, 11,000 individuals screened, out of which almost 1,800 couples, and randomized into immediate treatment. And these are people with CD4s that were at that time not what WHO was recommending be treated at that time. And then the delayed arm waiting until they hit the threshold of 200, and then in the middle of the study changed to 350. So we kept following the national guidelines, WHO guidelines. So you can see a little bit of why some people were excluded. And it was a worldwide study in the Americas, in Africa and Asia. So one likes to see this, improving generalizability of the conclusions. And the retention was quite remarkable. A lot of money was spent on this study, and I won't say that we adopted them and took them home, but almost. We really made every effort to retain couples in this study. Now, some couples were not retained as a couple because they split up. But we did all intent to treat analysis, very conservative analysis in this study. And even after the preliminary results were released and everyone was offered therapy, we still had a very substantial proportion of people who stayed with us all the way until the end of 2015. Now, this is the partner infections data. It's a little busy. I'll just point out that even if you look at the early data from before the definitive results were obtained to the final study, no matter how you look at it, you end up with substantial risk reduction of 69% for all partners, but the linked partners is the fairer comparison, because some people got infected from somebody who wasn't their regular partner, and they hadn't been suppressed in their virus load in the study. So you can't really count those as a failure, because they basically did not get treated, and therefore it wasn't a good test of the concept. But even if you included all transmissions, you had a 70% protection rate, but 93% is probably the best estimate. So the conclusions were the benefits of early ART in HIV prevention was durable. It lasted a good 4 or 5 years after the initial study was completed. The preliminary data were released. There were no linked transmissions when the index participant was stably suppressed on ART, as Tom told you. There were substantial clinical benefits of early ART for the infected individuals. Patrice is in the audience. He did a famous New England Journal study on that topic. ART is highly effective for prevention of sexual transmission of HIV. That's the bottom line. And then our network, the HIV Prevention Trials Network, tried to see whether this could be translated into a real-world setting without the extraordinary efforts of a clinical trial. Because in a clinical trial, you have an unnatural and perhaps unreproducible environment, because we're spending millions of dollars to maintain people in a clinical trial environment, maximize the suppression of virus by maximizing contact. It's simply not translatable into an African or Caribbean or even an American context. So, talking about the 071 so-called pop art study, this is their most interesting recent publication. I commend it to all of you. Fascinating data. This was the recent data from coverage data, and this was the study of the the description of the trial design. So if you're interested in trial design, and if you're interested in two of the more high-impact recent papers, I commend all of them to you. The study is going on in Zambia and in South Africa. And the question was, can we increase HIV testing and ART coverage adherence enough to actually drop community-level HIV transmission? Not a mathematical model, not a theoretical question, but a real-world question. Can we get enough people treated? Now, there is a mathematical model that was published in Lancet a number of years ago, and I never was too fond of that model because it said if everybody is screened in the world twice a year, and as everybody's put on therapy, and everybody's suppressed, then the epidemic goes away. And I didn't like that because I was taught to do mathematical modeling with plausible assumptions. And those were not plausible assumptions. I could do a mathematical model right now to say that if every single needle used is sterile and every single sexual contact is with successful use of a condom, the epidemic will go away. But that's not a very interesting mathematical model either. So this is based on much more realistic modeling estimates that Ann Corey has spearheaded from Christoph Fraser's group. And it's a cluster randomized trial, but in real-world conditions. And that's exactly where it is. It's up and down from north to south in Zambia, all the way from Livingston near Victoria Falls, all the way up to Ndola in the Copper Belt and the Congolese border. It's in a smaller region of Western Cape in South Africa, and you can see the locations there. So this is a very busy slide. I'm only going to mention it briefly. The full pop-art prevention intervention, a combination intervention, which is anchored on universal test and treat. And that's immediate ART, irrespective of CD4 count. Arm B was the pop-art intervention, except that it was ART initiation according to current national guidelines at the time of the study. And then Arm C was standard of care, whatever PEPFAR and the Ministry of Health and the Global Fund was doing, which was a lot. And the package was based on these so-called CHIPs, community HIV care providers, who went house to house in both rural and urban areas to offer home-based testing. And it's home-based testing that's the only testing that's ever gotten us to beyond 90% in Africa. We've never had a study published saying we can get more than 90% of people treated other than the studies that offered home-based testing. And we've been criticized for that. People said, that's not realistic, it's too expensive. But if you're serious about 90-90-90, you'd better have some provision to reach out to the very many people who are simply not coming to the clinic to get tested. Health promotion, including voluntary medical male circumcision, prevention of mother-child transmission, HIV treatment care for all positives, promotion of sexual health and TB service and condom provision. That is the pop-art, the full pop-art intervention. We had triplets that were randomized. So similar communities, 3 similar communities were grouped as triplets, and then you randomize within each triplet. And there's a total of 21 communities, 12 in Zambia and 9 in South Africa. And then we have a population cohort, a 2,000 random sample from each community. So the population cohort is 42,000 individuals at each population cycle. The 3 cycles of the study, those 42,000 people are being studied over time. So this is the largest prevention clinical trial that the world has ever attempted. And the package includes this universal testing and the home-based testing facilitated by these community workers, nicknamed CHIPs, service provision for all the things I just mentioned, universal treatment. So you have to go to the house, you have to go to the circumcision facility, you have to go to the health center, and you have to work in all 3 contexts. We have electronic data capturing that is permitting us to track these households, enumerating them, providing education, reporting, offering the testing, condom provision, referral to care, and active follow-up. All of these are being recorded on the handheld devices. And we changed the design after the guidelines that Tom showed you in his talk a moment ago. When WHO said everybody ought to be treated no matter what, we went to the ministries and we said, would you permit us to treat everybody, even though you haven't changed your guidelines in your country yet? This is an NIH-funded study. NIH would like to follow the WHO guidelines. The HPTN would like to follow the WHO guidelines. By the way, it was a big fight, because we were getting ahead of the policymakers in the Ministry of Health, and we knew that, and it was very, very difficult. And it took us almost a year to get them to agree to let us treat everybody. So now there's a bias towards the null. The Arm B is kind of an intermediate group between Arm A and Arm C, and the most interesting comparison will be Arm A and Arm C. But we'll have an intermediate group that had a big component of this, and then in the middle of the trial, we started treating everybody. And we think, that was the right thing to do. Now, the first 90, we haven't gotten there yet. So this is the estimated testing update, and this is the end of round 2, beginning of round 2, end of round 2. And even though we have considerable resources from the NIH, from PEPFAR, from the Bill and Melinda Gates Foundation, we still haven't gotten there. So just let's reality test here. Do I want to buy into the optimism that Clive started out our conference with? Yes, I want to buy in. But we have big question marks as to whether in a rural and urban African setting we can actually achieve the coverage. Remember what happened to the ANRS study in South Africa that Tom highlighted for you. They did not achieve the coverage rates, and they did not achieve the prevention. They had a lot more people treated, but not enough to reduce the community-based transmission. So this is the question of 071. It's also the question of the CDC Botswana study. It's also the question of the SEARCH study, a number of these studies. This is the bigger one, I guess, and therefore commanding a lot of global attention. Now, the fact that we actually got to 90 for women on the estimated total HIV positives and then the known HIV positives. So this is the estimated total, and this is the known. And we managed to estimate that we came close, but it's hard to know. Now, the second 90 is the time to linkage to care. This is giving you a sense of age groups, and there's a tremendous difference in the age groups. The proportion linked to care in the middle age group versus the older age group. Now, the months since referral is here, and then the proportion linked to care is here. So there is a wide variety. Young people were more willing to get linked in Zambia. They were less willing to get linked in South Africa. So you have differences between countries. You have differences between age groups. And I'm going to step away from the mic symbolically for a minute and just look you in the eye and talk to you about 90-90-90. Because 90-90-90 means 72% of the people are suppressed. That means there are 28% of them who are not. We already know from very important data from Britain among gay men, surveillance data from Britain among gay men, that they've already achieved 90-90-90 in gay men, and they haven't seen any diminution in incidence rates among gay men in Britain, okay? So I'm going to tell you that the modeling that assumes homogeneous risk among the population that says 90-90-90 is good enough is wrong. That modeling is wrong, and it's predictably wrong. What is really occurring is that 28% is not a random sample of the 100%. That 28% overestimates people who are not following what WHO wants them to do or the Ministry of Health wants them to do. How many times have you been in a public health setting where you spend 50% of the money to reach 90% of the people? Now you have to pay 50% more to reach 5% more, and you're still left with 5% you're not able to reach. This is the story in the vaccination world. This is the story in so many circumstances of at-risk populations. So when you have 28% of people who are not covered, not virally suppressed among the 90-90-90, they are not a random sample of the 100%. They are an especially difficult to reach subsample, and in Britain they think those are the men who are disproportionately sexually active contributing disproportionately to the epidemic. So the same people who are not following prevention health messages, not following you know, the 90-90-90, they're more likely to be at risk. It's perfectly logical, right? Who's going to be the first person to walk into a drug treatment center? A drug user who is highly motivated to get drug treatment. Maybe a woman who's just become pregnant or whatever. It's not a random sample of all drug users. There are plenty of drug users out there who don't want to give up drugs right now. They eventually will, but right now they are injecting and they're perfectly happy to be left alone injecting. The same with sexual behavior. There will be people who say, I'm tired of my lifestyle, it's too risky, I want to reduce my lifestyle. But, you know, there are people who say, look, I like my lifestyle. I want to use drugs, I want to have sex, and I don't want an HIV test. So you've got to take this with a grain of salt. With all due respect to UNAIDS, with all due respect to the modelers, they're not thinking about this right. So now I step back to the microphone, continue my life. I never said that. Then you look at the proportion initiating ART. So this is the second part of the second and getting into the third 90. And, you know, we're not quite getting up to 90% in the proportion initiating ART. Better in men than women, which is not what you'd expect in Zambia. You'd expect the other way around. And it's reversed in South Africa, more among women than men. So the more we claim that we know what's going on, the more we actually need data to find out what's going on. Because none of us would have predicted this. None of us would have predicted that the men in Zambia would get to initiate ART at higher rates than the women. Because that's not the stereotype. But guess what? These are the data. This is what we found. So achieving improvements in linkage to care and ART initiative, you've got to have these initiatives for linkage to care. And this is the focus of our community workers, focusing on known HIV positives who are not on ART. So we're redoubling our efforts to get out there and find these people and get them into care, because some of the folks who are not coming into care are some of the highest risk individuals. We need the training and comfort in universal test and treat. There's still some old ideas out there. They feel uncomfortable treating a perfectly healthy person. You know, they perceive them as healthy. They have a high CD4, and our healthcare workers sometimes don't do it. Community messaging is critical, as you can imagine, and once clients attend clinics, the uptake of universal ART is highly accepted. So once you get them into the clinics and you can educate them, and on balance, the men are similar to the women, although there were the differences in the two countries. And then again, looking at well, let me skip this one because I'm running out of time, and that one's a complicated slide that's of less interest. This is the retention on ART and adherence to ART. This is by self-report. And we're getting pretty good adherence. These CHIPS workers are miracle workers. You get the relationship between a community health worker and their clients, and people are much more likely, and you've seen this in Haiti, you're much more likely to adhere to their drugs. And you remember Paul Farmer's accompagnateurs way back 20 years ago. So there is plenty of reason to believe that once you get them into the clinic, once you get them on therapy, you can keep them on therapy with this extra boost. Uptake of testing, this was the known status after the self-reported HIV or testing by the CHIPS, and the known status before. We had a special adolescent focus in this study, and we have been reasonably successful. We're getting the adolescent coverage massively increased, 15, 16, 17, 18-year-olds, men, women, and we're able to get testing up with special adolescent focus. So if somebody comes and tells you you'll never be able to test the adolescents, refer them to this slide. It's not true. We can do it if we make set our minds to it. And there's lots of adolescent activities and services. Adolescents are neither visible nor easy to locate because a lot of African adolescents are not in school anymore. Total stakeholders were fewer than expected. You know, we had in Zambia, for example, we had 37 groups that were focused on adolescent activities in 8 intervention sites, and ranging from 9 groups to 1 group. We thought there were going to be a lot more people working on adolescents. We didn't see that many. And the stakeholder types are, you know, the facility-based organizations, the community-based organizations, the non-governmental organizations, school programs, support groups, health facilities, and there were school and HIV programs in both countries, but they weren't being run very well. And there's a real focus on self-esteem in teenage pregnancies, particularly in our South Africa interventions. And we found very limited communication between parents and adolescents about HIV and sexual reproductive health, which is probably true in the state of Connecticut, where I'm from, and probably true in Barbados, where many of you are from. So, you know, no different in Africa. Where are the men? This was one of our biggest problems. We were not reaching the men. They were reached at, you know, here's 9 to 5, 10 to 6, 11 to 7, and we found we were reaching more of them in the 11 to 7 range than we were earlier. Why? They're out working. So you go and send chips at their convenience in the daylight when it's safe to go around the, you know, South African townships or, you know, in the rural areas, but that's not when the men are home. So we had to bite the bullet and start with weekend, and that took a lot of negotiation with the unions, which are very strong in the Western Cape. We had to negotiate weekend time, and it was very complex, but we managed to do it. And the key issue is, how about a weekday versus a Saturday? You'll do much better on a Saturday getting the men. So these are the sorts of things, mid-course corrections within the study that we've had to do, because our goal is not some pure randomized trial that doesn't change with time. Our goal is to increase testing and viral suppression in as many people in the community as we can. So every time we've done work for a year, we've had lessons learned, and we've had to redouble our efforts and improve our study. That's why I call it it's a randomized clinical trial, community randomized clinical trial, but it's in a real world setting, which is continuously trying to improve itself as you go on. Strategy to reach men: first, asking men what they wanted. HIV was not the most important thing in their lives. They had other health issues. They wanted male-friendly spaces. They didn't want to be mixed up with you know, the general population. And they wanted interesting activities while they were waiting and while they were engaging healthcare. So we provided a range of health services as they told us to. We had football matches and performances to lure them, and we even had a raffle. Very successful. Now, community outreach, what has worked and what hasn't? Lots of people have come to community outreach, have accessed many health services, but registration of people into their households was challenging and time-consuming. Just because they came to a street fair didn't mean that they engaged us over the long term. Some of them come to a street fair just because they want to sample the services and leave. It was very costly. We did not get the big yield that we were hoping for, and we got a few additional men in households, but it did help us reach the last 20. You know, we got to 80%, now we're trying to reach the last 20, and the community fairs did. But you see, this is the nature of public health, isn't it? It costs you X to get 80%. Now it costs you 2 times X to get the next 10%. Then it costs you 4 times X to get the final 10%. That is the nature. I've been doing this my whole career. This is the nature of public health. Mobility and migration. Again, my time is short. I'm going to skip this just to say that a lot of people are not there the year after you came to visit them. Plenty of migration. Sometimes it's just between their township community and where they're from in the rural area, and then they might come back again 2 years later. A lot of people following jobs. And if you think that Africans are sitting in their home indefinitely, that's not true. They're in this home, then many of them are going to a different home, so there's plenty of migration. Challenges of keeping people in care: long waiting times for clinic review and pharmacy for refills. So we've initiated a study within a study to reduce that. Pharmacy capacity, storage space, and staffing issues. We've had to get additional money to deal with that. Stigma, especially towards adolescents and men. Migration in and out of communities. And some of our lessons: exploring alternative ART delivery. For example, having group acquisition, so somebody gets all the pills for their friendship group and then distributes them, so nobody, you know, one person stands in line, not 6 or 7. This is a concept borrowed from MHS in Tete province in Mozambique. Enhanced staff provision, storage space, staff training, adolescent-friendly areas and times, and then there was a higher than anticipated change in addresses. Therefore, we need repeat household visits, because 20% of people weren't there the next time we came. That's not exactly going to help us achieve our goals. So that's the acknowledgement of the funding agencies, and it will be finished a year from now. And then it'll take a few months to finish all the lab tests and analyze all the data. But late in 2018, you should hear the results of this study. If it is negative, we will be immensely disappointed because the resources that have been put into this, the care with which the work has been done, that will make even Clive a little bit discouraged. If it is positive, it gives us a model and a way forward that yes, we can achieve community level coverage for universal treatment and suppression adequate to actually benefit others, not just benefit the individual, but oh, there I go. Okay, you know, I had a little section about PMT-CT, and I'm going to leave it up to the organizers. It would take about 10 minutes, so maybe I'll skip it. The only point, let me just summarize the point on
10 minutes is too long.
It's too long.
Yeah.
Yeah. So the PMT-CT point that I would have made is that was the first universal treatment as prevention. Was treating a mother to protect a child. That's treating one person to protect another one. What's universal test and treat? What's universal, you know, treatment as prevention? It's to treat one person to protect another. So I just wanted to remind you of that. And we're making nice progress in the PMT-CT arena. And if anybody wants these slides, just send me an email, I'll send them to you. And we're making good progress in the original treatment as prevention scheme, which is PMT-CT. Some of what has been mentioned this morning about point of care testing, male engagement, joining the mother's study with the visit with the baby's visit, task shifting. That was a study that we just finished, and I meant to show you the reference. This one here in Nigeria, and we had massive improvement of coverage, and the equivalent of a PEPFAR, of a POP-ART study for mother and infants, because we substantially increased coverage with those 4 interventions. So I'll race through, and thank you for your attention.
Thank you. Time for a few questions.
Brandon Bain. Thanks, Tom and Sten, for this pair of papers, which I think gives us a lot of food for reflection. And I hope that in our national programs, we will think about how to adapt to each local situation. The predominant impression I have from listening to both of you is that the implementation of treatment as prevention is really the central message, and that there are a lot of practical issues in our individual countries. I want to say thanks for including that one slide, 2 slides that emphasize combination prevention, because I think we must remain fixed on multiple methods in combination. At the University Hospital, where I'm working in Kingston, something has happened when I was on a break that I think has really been helping our patients. The pharmacy has set up an HIV station, an ARV station, linked to the HIV program. And the feedback from the patients is that it's really helping them. It's encouraging them, and I think it's going to be benefiting adherence. So just tell that as a brief story. I know that it's difficult to make changes when you have a system in your country, but a change that has been made at that site is helping our patients, and perhaps others can learn from that.
That's excellent. Thank you for sharing that.
Patrice.
Yes, Stan, quick question. Community drug distribution is expanded more and more in Haiti. In your experience, the community health agent that goes into the home of patient, how frequently they go, and do you ask the patient to come back to the clinic for evaluation, and how frequent does that happen?
So your second question first. All positive individuals are facilitated for linkage to care, and we will visit them as often as we need to get them to care. We weren't doing as good a job in the first year, and we had to redouble our efforts because we were failing on the second 90. We were failing on the linkage to care, just as the NRS was. We will go back repetitively. The routine visits are only yearly. However, there are a lot of interim visits as necessary. For example, if we find that the male is not home, we go back. If the adolescent is not home, we go back. So there is a sense that the average household is getting visited about 2.5 times. But on schedule, if we go and we screen them and we get everybody in the household, then we see them a year later, unless somebody's positive, in which case we come back and link them to care.
Carol Jacobs, Barbados, and I want to thank you for a really fascinating and informative presentation. Barbados has committed to treatment for all, and I am particularly interested. In fact, I think the thing I liked best about your presentation was you're away from the mark, from the mic.
That never happened. That never happened.
Yes, I didn't hear it.
Gets me in trouble with all my friends in Geneva.
So my concern is that 90% treatment, and I'm very interested in your CHIPS home-to-home testing. I have a few questions. First of all, how much training do you invest in the people that go doing that? What kind of rejection do you have of those people when they go to the homes? Costing and resources, because I see you have some basic equipment that you give them. And finally, I think our problem is getting to the at-risk people. And how do you do that? Is that special training? Because it's
So
very
which
different
people? I missed the last.
going into getting to at-risk
At-risk people,
populations.
yes.
Because it's very different dealing with at-risk populations, for example, or young men on the block, as different from a normal.
So your last
class.
your last question first. Since this is designed in a community setting of Africa, we're getting the at-risk people by going to their homes. So we're enumerating all the homes in a region, and if you're in A, you're getting the home-based visit for testing and all the linkage and the pop art intervention. If you're in B, you're getting that, and for a little while, you were only getting referral when you were below a threshold, and now everybody is. And then C, we don't go to the homes. C is just the enumeration of the population cohort to see what's happening in those communities. We are offering substantial training to the CHIPS, and again, you know something, we had to offer repeat training to the CHIPS. You cannot underestimate what it will take to recalibrate people in the community who don't understand the concept that an HIV positive test is good enough to treatment. Because for 25 years, we've been telling them that no, only a low viral load. So it's requiring a lot of training and retraining and a lot of quality assurance oversight.
So is it realistic?
Well, that's what
Because
people
you
say.
don't
That's what
believe in
pe-
1990.
That's what people say when they criticize the study. They say, you know, you try to do something that was real world, and no, it's not 052. I mean, 052 was as expensive as this was, but for a tiny fraction of the population. But if we don't give it a fair try, if we don't actually try to get to 90-90-90, we're not answering the actual question. So we thought it was worth the extra investments to actually find out if we achieve 90-90-90, do we actually suppress transmission in a real world setting? Because the NRS wasn't a very helpful study at the end of the day. They didn't achieve their coverage goals and then it didn't work, so what did we learn? So that's why we've made the extra investments, that's why Gates came on. No, it's not completely generalizable to especially Africa, but I'll tell you what we're doing is quite doable in Barbados. You could in fact have, maybe you don't really need home-based testing because you're an epidemic driven so much by key populations, but the concept of having substantial investment in community health workers and peer counselors and outreach workers might be quite realistic.
We have two other questions.
I didn't answer all your questions, sorry.
Stein, thank you very much for that very insightful presentation. And you almost answered the question at the very end. I was interested in the giveaway that you mentioned towards the end of the presentation on task shifting. And I wondered if, to cut this long story short, if, for example, the experiments that you've carried out would provide some lessons as to what are the best options for task shifting, especially for countries like the Caribbean.
Right.
Because you can have a community base,
Right.
but you can also have the other technical
Right.
aspects. So which of the options is emerging?
Yeah.
As a,
So our CHIPS workers in Zambia and in South Africa are not sophisticated college graduates. They are high school graduates or sometimes less, and they are literate. They have to use the handheld, but they are not drawn from a high-paying, high sort of elite public health cadre. They don't have all master public health degrees. So we are working with almost a peer-level community health worker here. And that's why the training is so critical, and the retraining and the quality assurance, because you're not getting a group of highly sophisticated individuals who completely understand everything the first time you explain it to them. You're getting a cross-section of the kind of people that you're actually trying to impact in the community. So I do believe that we've shown that we can get very high coverage rates for home-based testing, over 80%. We can improve our connectivity and our linkage rates substantially, and we're not using nurses. We're not using nurses. We're using community-level workers. So that's a big vote of confidence in task shifting.
Last question, if you want to pause.
Well, thank you for giving me the last question. My name is Alexander Pastoors, and I'm very glad that you pointed out the pink elephant in the room about the modeling about 1990. Thank you very much. What I also want to point out is that after that...
If you liked what I said, my name is Sten Vermund. If you didn't like what I said, my name is Tom Quinn.
But there was one thing that which drew my attention, is that you mentioned just after that, it's like, well, apparently people aren't following our advice or our methods of prevention. They're not doing exactly what we want them to do. And I just wanted to add to that is that, yes, probably you're right. And of course, we have now very recently new evidence that if you offer people a method of prevention that is actually fitted more to them what they need, they actually will do it. And what I'm pointing out is that, of course, look at informal PrEP use among gay men in the London clinics, which led to a dramatic drop in infections of over 40%. So it's not only a method of saying, well, they're not doing what we want them to do, but it is also a way of actually offering people what they need and what fits best with their personal needs. That's what I wanted to say.
I think that the 90 for some good will be plus PrEP.
Yeah.
If we want to eradicate. That's what Montreal will propose.
Yeah. Well, your ringing endorsement of community engagement and partnership with communities and finding out what communities think they can do to reduce HIV, I couldn't agree with more. Thank you.
Thank you very much, both of you.